By the way, the sequencing here, this is just how I'm doing it for today. I would say that for the way that I do lumbosacral, yes, I have a very specific sequence because it's pretty difficult to palpate, and then so the 1 through the 1, 2, 3, 4 lines, so the PSIs, that kind of thing. For the shoulder, I don't have anything quite that specific, but it's in the same keeping that you typically want to mark the areas that are easy to palpate first, and then do the harder stuff later, right? So the things that are relatively easy to palpate, and of course with Mark, he's very svelte, and so pretty easy to palpate and mark a lot of the landmarks here. Okay, so hopefully Mark's anatomy does not, kind of counter what I'm going to discuss here. But one of the things about the acromion, look at how, let's say this is like width here, look at how wide that thing is, right? I mean, that sucker's like, how tall you are?
6 feet.
Okay, so he's 6 feet tall. So taller than the average Honduran, certainly, but I mean, that sucker's gotta be about 6 centimeters wide, right? In general, it's about 5 or 6 centimeters wide. That's pretty dang wide, right? Now, one of the mistakes that people will make is that they will only mark the acromion maybe something like about that wide, all right? They cut it in half, right, roundabouts. So things to consider are that the acromion also, now for Mark it doesn't quite look that way, but in many cases it's tilted like this. So it's more superior along the anterior edge and more posterior, can I wiggle my thenar eminence? Inferior along the posterior edge. It's like this. But we, as Prolo therapists, often think of it as being just kind of horizontal like this. So if it's horizontal like this, and that thing starts to slope a little bit posteriorly, we kind of lose this part, and we kind of mark it somewhere over here, or maybe we mark this one accurately, but then we mark the anterior one like over here somewhere. Point being, this acromion is freaking huge, right, from a length standpoint, so don't forget that. And then of course your intra-articular is going to be in this little soft spot right there. That one's pretty easy to find. What's down here that you don't want to hit? If you go more inferior and go deep, what's in there? Which one?
Posterior axillary.
Axillary nerve in the quadrangular space, right? Now, granted, when you're doing these things under ultrasound, you're actually purposely going in there, right? There's like a technique for an axillary nerve hydrodissection, but that, of course, is beyond our lecture here.
If you were trying to hit that nerve on purpose, what would you do?
Great question.
I don't know. Yeah, if you're doing it without image guidance, I am not sure what my technique would be.
It comes down and then it loops around the humeral head a little bit lower than the neck. So sort of like genicular blocks, they tend to course along the metaphyseal flare. I'd be feeling for that, and then I'd be going down to bone, and then sort of like large volume.
Yeah, as I think about, and the only issue is you don't want to peg anything that's along the bone, so I would have to, as I think I'm approaching the humeral kind of head neck junction area, I would be injecting as I go, so that in case the nerve is in front of my needle, it pushes it out of the way a little bit so I don't spear it. Then once you touch bone, then you flood. That would be actually a reasonable non-image guidance.
That's how I do it if I was trying to hit it and not worried about the
So where can you point to where you think there would be a spot that you could potentially hit right?
Yeah, it's basically if you go under the infraspinatus / teres minor, you'll feel the edge of the muscle right there, because that quadrangular space is superior border, I believe, is teres minor, I think. So yeah, basically right there. And then you can start laterally. Oh, that's the other thing is when you're hitting that bone, once you, let's say this is your humerus right here, then you can walk medially until you kind of fall off the edge, then come right back here and then flood that area. So you gotta figure out where on the humerus you are. If you just hit bone and you inject, the problem is if you're too far out here, fascially you're not gonna get the nerve. You're gonna be too far lateral. So you gotta walk it somewhat. But every time you walk it, you risk hitting the nerves. It's like you gotta be careful on that one. Anyway. Okay, so we've got this. In no particular order, one important point is that, and I think you've heard this already, or some of you that we work with in the marketing on Saturday, that the clavicle, the AC joint, right? The clavicle takes up the anterior half of the acromion, right? And then so I'm going to come back to the V later because the V is one of the more difficult things to palpate. But just when you're visualizing, when you're looking here, you can kind of see Mark's AC joint right there, right? for the most part here, it's taking up the anterior half. A lot of people will kind of draw this thing, and I'm going to draw errors too, so hopefully it doesn't look too confusing and too weird and all that kind of stuff. But you know, they'll draw something kind of like this, right? And then when they draw the AC joint, they kind of do something like that, and they're kind of drawing the AC joint as like taking up the entire length of the acromion, and that's not correct. It only takes up half of the acromion, right? Acromion, huge bone. Okay, so now we're going to work on the clavicle. So some people, actually most of the people here, actually most people in general, most Prolo therapists as they're learning, they don't go all the way medial. They kind of start somewhere out here where it's, you know, some sort of easy to palpate, right? And then from here, then they start drawing more laterally, right? And it's like the medial aspect of the clavicle is sort of like lost in space somewhere, right?
Can you show if people identified it too low and are actually marking the first rib?
Ah, yes. Okay. Well, okay.
As a caution.
Yes. So a lot of the lecture that hopefully that I'll try to send to you, one of the specific errors was like this list of like errors, and I'd separate it between like anterior, superior, and posterior shoulder, and the common errors is that do not mistake the first rib for the clavicle, right? Now, first rib, and sorry we don't have a bony model here, but the first rib is kind of small and it loops sort of like this, right? And where it attaches, and I'm sorry, I don't mean to shout in your ear.
Right, all right.
And where it attaches medially is directly inferior to the sternoclavicular joint and slightly lateral. So, thank you for bringing that up. I'm going to go ahead and mark the sternoclavicular joint because there's a couple of very important notes for this one.
While he's marking that like mistake, the inferior aspect of the medial clavicle is like one of the top ways that you get a pneumothorax if you were trying to do an SC joint injection. And so similar to our follow the biceps femoris to the fibular head, the sternocleidomastoid is a great big muscle that you can get them to flex, and that has clavicular and manubrial attachments, and that can help you confirm the location of the SC joint. If you have them kind of turn and make them sort of functionally give themselves a torticollis, you can follow that sternocleidomastoid tendon down and differentiate clavicular and sternal attachments to verify, okay, here's where those attach, this has to be my SC joint, as opposed to the first rib, which is just underneath it.
Okay, so for the sternoclavicular joint, the most common error here is that people mark that medial edge of the clavicle. They mark it too laterally, right? They'll mark it out here, almost always. I would say at least 80% of the time people will make that mistake. So, sternal notch, right? Now, it's been a long time since I've done general medicine, but basically that's, you know, in terms of figuring out how to place a tracheostomy tube, something like that, right? I'm gonna embarrass myself with my lack of recollection on this. But that sternal notch is is like your primary landmark, yeah? Well, what forms the and that, you can see, you know, the sternal notch is not that wide, you know, it's a couple centimeters, right? What forms the lateral borders of the sternal notch? The clavicle, right? The clavicle. So the clavicle is pretty medial in terms of that medial line. It's right there and right there, not here and here. So why do people always mark it out here? Well, there is a little ledge right there that's kind of on the medial aspect of the clavicle, but it's because of how people, at least in my experience and opinion, it's because of how people visualize the manubrium, right? The manubrium is wide. And so what they imagine is that if this is my manubrium, that the clavicle attaches on the lateral aspect of the manubrium. But it doesn't do that. It sits anterior like this. So it overlaps the edge of the manubrium. As you can see in this marking here, here's the edge of the manubrium right here. First rib is actually, you know, right there. Here's the medial aspect of the clavicle. But people visualize that clavicle is going to be more lateral like this, right? And it's in line with the lateral edge of the manubrium, but that's not what the anatomy does. The anatomy does this. As a result, you're going to have a more narrow distance between the medial edges of the clavicle. Now, why is that important? Because what is the significance of this sternoclavicular joint with regards to an actual well, I shouldn't ask that question that way. All right, basically, the sternoclavicular joint is the only articulation of the entire shoulder complex with the axial spine, right? The damn shoulder doesn't attach to the axial spine anywhere else through an actual articular joint other than right there, right? Because everything else goes to the scapula, and the scapula floats in space. It's attached by a whole bunch of tendons and ligaments to the shoulder, right? There is no other articular attachment. That so-called scapulothoracic joint, it's not really a joint. It's just a bunch of muscles and ligaments and fascia and stuff like that that's attaching the scapula to the rib cage. So this sucker is actually critically important to examine and treat, because it gets a lot of stress that it kind of goes under-recognized, if you will. So that's actually a very important spot to treat. But to Greg's point, you don't want to mistake the first rib here for the clavicle, and some people have a more prominent medial first rib than others, and it can be difficult to differentiate the two. So you have to be, and one thing that'll help you is to make sure that you mark the superior aspect of the medial clavicle accurately, because you're going to realize that the clavicle is not going to be like 3 centimeters wide, right? That means that you're including first rib and clavicle. It's going to be more like maybe 1 centimeter. Well, with your perceived edge, it's going to be maybe a little bit thicker than that, right? Now, you heard some of me tell you, okay, so then from there, we're going to move laterally. What time is it, by the way? 8:36. Sorry? 8:36. 36. All right, so we got maybe 15 to 20 minutes. All right. You've heard some of me say that the clavicle changes shape as you go laterally. So it changes from a cylinder to a flat sort of rectangle, if you will. Have you had an AC injury at all, Mark?
No, born that way.
Okay. I'm not bad, I'm just strong now, baby. All right. Won't ask for which movie that's from.
Please don't kill me.
All right, Roger. All right, so the shape of the clavicle changes from a cylinder here, where on one particular skeletal model I measured the diameter at 8 millimeters. And as it proceeds laterally, it flattens out to a diameter of 15 millimeters. So the diameter of that clavicle in the anterior to posterior plane doubles as you go laterally. It's not just a cylinder, right? So what I've marked here is as close to accurate as I can get, but I'll show you the common mistakes. There are 2 of them, 2.5. One is that they draw it such that the diameter doesn't change, right? It's like they visualize it as a cylinder all the way through instead of widening at the distal aspect. And the second thing is that they visualize it as not that they visualize, but what they palpate, what their fingers tell them is that it's straight and it doesn't have, an S curve. Here you can appreciate a bit of that S curve right here. Now the reason that people draw it straight, there's a couple of reasons for that mistake. The number one by far is because there's this damn thing right here, right? This trapezius muscle. So this upper trapezius comes out where you can see and mark the border of this muscle, yeah? Well, if you mistake the border of this muscle for the border of the bone, then what people do is that they mark a line like this, and so what they end up doing is something that looks very much like this, right? And then they kind of do like this, and then it ends up being like this straight bar going across, all right? But that's not accurate, that's not correct, all right? Now sometimes they might mistake this is another point, 2 other points in my presentation. One is, don't mistake the coracoid process for the lateral clavicle. In shorter people, when that distance is closer, it sometimes is hard to tell, and then they might do some kind of funky thing where they mark this clavicle coming across like this, or you'll see all kinds of weird stuff, right? Now for Mark, because he's taller, there's a greater distance between the clavicle and the coracoid, so it seems a little bit more ridiculous that somebody would make that error, but oh yes, we see it. And while we're at it, the other thing is, do not mistake the second rib for the clavicle. So you know how I told you yesterday that the second scariest thing I ever saw was that foreign needle being buried, hopefully not in the rectum, but possibly in the rectum. Well, the scariest thing I ever saw was when a very skilled resident, he was actually one of our better students, but he was arrogant. He had the patient prone and he was bracketing, actually it was this way. He was bracketing what he thought was the coracoid process, but it was actually the second rib. I'm sorry, supine, yeah, supine. But he was actually bracketing the second rib, and he had his needle, and he was literally like 3 seconds away from going down. And I literally, I was, you know, that was my first or second year as clinic director, so I'm you know, going to room, and I peeked in there just in time to see him do it, and I go in, it's like, stop, and he did not want to stop. I actually had to grab his hand to stop him from going in there, and I had to dress him down a little bit. So by the way, when the instructor tells you to stop, okay? Now, I'm kind of preaching to the choir. You guys have been amazing, by the way, as a group overall. But you'll notice that, yes, you have a bony prominence there, all right? Now that second rib is gonna traverse a little bit more like this. So, you know, I'm just gonna kind of do a little thing there. And I'm gonna put a big X through it, and I'm gonna write no. All right, so bony prominence. Now it seems ridiculous, but I tell you what, you know, especially in the brigada situation, it's Thursday afternoon, you're freaking tired, you've treated 50, you know, patients this week, and then, you know, you got a big patient, hard to palpate. So I talk a lot about ratios, right, and about the overall location of different things. If you just step back and look, and the value of stepping back and just like looking at your drawings for a second before you continue can be immensely helpful. I've marked, I don't know how many thousands of patients. I try to do this all the time because I still make plenty of mistakes. I make plenty of mistakes when I mark, and I've been doing this for almost 20 years. So when you step back and you look, that just looks too medial, right? I mean, it's like, you know, in the middle of the clavicle from a medial to lateral standpoint. That's not where the coracoid process is, right? By the way, the coracoid process typically is at the apex of the concavity in that anterior clavicle. That's one thing that helps you get a general sense of where that coracoid process is. It's like, you know, you got your little cup, your little curve right there, and it sits like right. I mean, heck, evolutionarily speaking, that's probably why the clavicle. Who knows how it developed there, but. Seems to make sense, you know? It curves to make room for that coracoid process, right? So don't make that mistake, right? Going back to the shape of the clavicle, it's not straight, it is S-curved. And the thing that'll help you the most with that is, number one, realize that you have to ignore the shape of ignore the trapezius, because it's gonna fool you. And the second thing is to realize that because the distal clavicle sort of expands, if you will, flattens out, the posterior edge of the distal clavicle is quite posterior. Those of you that I've worked with a little bit when we were working on shoulders, you know, I was always like, okay, so you feel that, now feel that right there. And usually I had to move your finger posteriorly about 1 centimeter, right, to find that posterior edge of the clavicle. And then once you're there, then you're pretty close to the terminus of the V, right? We talked about that V. All right, so that's the next piece. It's too bad we don't have a bony model here. But the V, what makes up the V? What is the anterior border of the V? So what bone is that? I mean, we just talked about it. That's clavicle, right? And then what's the posterior edge?
The acromion.
Are you sure? Scapular spine, yeah. Which runs
into the acromion.
Yeah, it runs into the acromion, yeah. There isn't really a lateral border because it's a V, but yeah, so the acromions can be on the lateral edge here, and you got clavicle and you got spine and scapula. The V is exactly that. It's a V. It's not a U. It's a V. And by definition, because the V is formed by the intersection of the clavicle, the acromion, and the scapular spine, by definition then, the AC joint has to be in line with where that V starts. That's what the anatomy looks like. It can't be any other way, because what the heck forms, you know, the terminus of that V, right? Well, it's the distal end of the clavicle. So this is where I gotta go through my wonderful this 3 divots thing. Has anybody here seen that movie Demolition Man with Sylvester Stallone?
Yeah, of course.
All right, the 3 seashells. Right, every time I look at 3, it's like, he doesn't know how to use the 3 seashells. Anyway, Rob Schneider, his little cameo. All right, so anyhow, when you're trying to palpate the AC joint, there's like these 3 divots that I talked about. You have the lateral divot, you got the middle divot, and you got this weird friggin' medial divot, right? So what is this? What's this thing here? And there's definitely a divot there. I mean, there's definitely something palpable. What is it? It's nothing. It's like this, it doesn't even have a name. I've checked like 4 or 5 different anatomical texts. I cannot find a name for this part on the bone, so I just call it the distal neck of the clavicle, right? So this distal neck of the clavicle is this divot, and you got this thing over here, and then you have this divot over here is the lateral edge of the acromion, right? So you got basically 1, 2, and 3, all right? Now the problem is there are 2 common errors that make you think that the AC joint is going to be more medial. One is you feel this medial divot thing. The second is because this terminal V is so difficult to palpate because of the thickness of the trapezius, a lot of people are going to palpate the V and they draw it like a U, right? I mean, I know some of you have done this, right? So instead of drawing a point for a V, you can't, it's so hard to palpate that you just, you know, I don't feel a V, but hey, it feels like it ends over here, and it feels like it's kind of like that. You end up drawing a U, and you're like, all right, well, then if you think, all right, well, let's see, the V is even with the AC joint. I feel this divot over here. Next thing you know, you're gonna draw that, right? Well, that's wrong, all right? So don't make the mistake of making that medial divot the AC joint. That's not the AC joint, right? It's like the distal clavicle. Don't make the mistake of doing this U thing when the tip of the V is more distal. And the thing that'll help you with that, 2 things. One is that we recognize that the distance from the lateral edge of the acromion to the AC joint is like 2.5, 3 centimeters, sometimes 2 centimeters in a smaller person, 3 centimeters in a larger person, somewhere between 2 and 3 centimeters. So I'm gonna like Mark, he's 6 feet tall. I always like to know how tall my patients are, because how tall they are is gonna clue you into the relative size of the anatomy. I do that for all body areas, for spine, stuff like that. Some of you might notice when I walk, if you're marking a low back, and I walk in, and I'm kind of looking at your patient, within the first 5 or 10 seconds, I look to see how tall the patient is lying on the table, because that's going to give me an idea of their, one of many things, of their intervertebral spaces, right? So, 2.5 to 3 centimeters, looks like it's about 2.5 centimeters in Mark's case. That's one thing that'll help you is recognizing what that distance is to the AC joint. The second thing is recognizing that the AC joint in symptomatic individuals or individuals that have trauma already have a lot of osteophytic change. So with that osteophytic change, that joint line can be pretty gnarly and difficult to palpate. Those of us that use diagnostic ultrasound, when you scan these AC joints, what do they look like? What's the name of that sign? There's a name for that sign. You got the, basically you have the edge of the bone here, you got the edges of the bone like this, and you get this thing that looks like this, right? It's called the geyser sign, because it looks literally like a geyser is like spouting out like this. So now, you don't have a nice clean joint line. You have this sort of like extruded capsular ligament that looks like this. Well, how the hell are you supposed to feel the joint line when you got this big capsular thing going on there, right? So recognize that this joint line might just be really difficult to palpate if there's pathology there. Same thing with osteophytes along the knee, right? So I've worked with some of you in trying to identify accurately the tibial plateau. And what's the rule that I talk about? That 90-degree angle, just as a little aside, going into you for a second, between the anterior tibia and the tibial plateau, this angle, both medial and lateral, is right about 90 degrees. It's like 87 degrees or something like that. Now the problem is if you got a lot of osteophytic change along that joint line, it's really hard to feel that joint line. So you're gonna have people that mark it like this, you're gonna have people that mark it like that, but anatomically, it pretty much has to be 90 degrees because it is a major weight-bearing joint, and because of gravity, you gotta have that sort of flat, perpendicular angle right there between the tibia and the tibial plateau. It's not gonna be all weird angled like this or like that. By the way, as a quick aside, so with that knee joint, all right, so now we got the knee joint like this. When you have osteophytic change, the joint line's gonna change and it's gonna look something like this, right? So when people are incorrectly marking that joint line, they're not feeling the joint line in the middle. What they're feeling is they're palpating this part, like superior to the osteophyte, or they're palpating this part inferior to the osteophyte, and that's what's gonna wind up having you have a line that's gonna be all, that's gonna be either too acute or too obtuse. Most of the time it's because they're mistakenly marking this part of an osteophytic joint line instead of marking the true joint line which in an arthritic joint might already be very narrowed and practically impossible to palpate. So that 90-degree sort of trick is going to help you have an accurate joint line, right? So, so that AC joint can be a little bit difficult to palpate, because of those reasons. But the distance here, and then matching with the terminal V, realizing that it's a V and not a U, will be helpful. All right. So and then the 3 divots thing. So don't mark the middle divot as the AC joint. Okay, so those are the major things for anterior and sort of superior and lateral. Now we can do a little bit of posterior. Posterior is not that complicated, but there are a couple of major things that can happen. What time is it?
It's 8:49.
5 minutes. Yes, thank you. Actually, what we're gonna do is you sit sideways, so sit sideways on the chair. So keep the chair still, but rotate your body 90 degrees that way. Yeah, there you go. Hopefully that works. Okay, good. Oh, by the way, questions so far with the other stuff? We're okay?
So for the she shells, edge of the acromion and then the clavicle, but that's behind the clavicle and halfway is the AC.
Yeah, so you have the lateral edge of the acromion, this distal neck of the clavicle, whatever the hell that thing is, and then the AC joint is like kind of in the middle. It's more or less in between the two, more or less. Yeah, so the middle divot is the AC joint. Go for the middle divot. Yep. They never clarified what the middle seashell did in the movie, but all right. So a couple of common errors here, and I'm going to do this fairly quickly for the sake of time. So it's not going to be that accurate, probably. That's not right. And it's going to be kind of that lateral border is kind of hard to palpate. I'm not going to do too much there. Ah, yes, it's coming back to me. It's all coming back to me. I'm not good at karaoke Celine Dion, not in public anyway.
Now that can be stuck in my head.
All right. You poor people. Okay. Now the scapular spine is a complicated structure, actually. Yeah, my drawing's off. Right. See, even now I'm like having to correct my own drawing.
There's a lot of anatomic variability of scapular spines.
Indeed, there is. All right, so I'm going to try to point out these major sort of potential errors here. Okay, so one of the more important ones is don't mistake the scapular spine for the superior medial border of the scapula. This one is super common. Now, why is that important? So what major structure attaches here that approximately simulates the angle of my finger? Levator scapula. Levator scapula is one of the most important structures from an MSK symptomatic standpoint that I treat. It's also one of, I think, 3 structures that I don't treat without ultrasound. I do not treat this structure without ultrasound. If you're treating it in clinic here, use ultrasound. Actually, yes, I'm going to make an executive decision. Clinic director, I pretty much never do that. But when you're doing, actually, we mentioned this a little bit, not so much for levator, but levator scapula or ribs, we have so many ultrasound units available. Use ultrasound. When I was in my first couple of years of being an attending, I had 2 colleagues, and the 3 of us did prolotherapy, and we kind of started the whole PRP ultrasound thing at our, at Harvard actually. And between my 2 colleagues, they each had 2 pneumothoraces within 7 months. One of them, the 2 of them, was within 4 months. The other one, the 2 pneumothoraces, within 7 months. And all 4 times, it was the exact same technique, which was using an acupuncture needle to do dry needling for the levator scapula without image guidance. 4 pneumothoraces. One of them ended up in the ICU. I don't remember if she had to get a pleurodesis or not, but she was in pretty bad shape. We did an M&M on her, actually. The other 3 weren't that bad. So 4 times, so I'm like, I am not doing that without ultrasound, all right? So I highly recommend.
About the ultrasound confirmation on the second rib?
Right, so, yeah, wait, was it ultrasound or fluoro? It was ultrasound. Wait, you know what?
I thought it was ultrasound.
No, actually, no, it was fluoro, I think. Yeah, it was fluoro. So, we tested this in Madison. I think I did it 2 years in a row, that one. I didn't do it as much as the other ones. But we had people come in and try to hit that levator scapula. And I remember the first year we did it, we had 4 people try. All 4 of them missed. 3 of them, okay, one of them where they were, the needle was actually not that far, but it was like over here. So it was on the scapula at least. Guess where the other 3 were? Second rib, right? So the second rib sits right there, and it's about something like 5 or 6 millimeters. No, I'm sorry, it's farther than that. No, it's about a centimeter away. About a centimeter away from where you want to be on that levator, on that medial edge of the scapular border for levator scapula. It's about a centimeter deep. And so they all had their needles on the second rib, and you can't tell, it's bone, right? And so you're like that far away from poking out the lung. So I highly advocate ultrasound for this. But see, the mistake that people make is they'll think that this is the scapular spine because it's easy, that this is the superior medial border of the scapula because it's easy to palpate, and they start injecting over here thinking that they're injecting levator, and they're wrong. Now you will get some potentially good stuff in here. You know, you get trapezius, you might get a little bit of rhomboid or something like that, but you're not getting levator. And levator has a distinctive pathologic, pattern and set of symptoms. So it's very important to be able to accurately get that levator scap. Many times you can't even palpate the damn thing. And then we have different positions and stuff like that that we can use, which I'm actually not going to teach because we would like you to use ultrasound for that. All right, so don't mistake that. Now, when you are marking the scapular spine, recognize that, look at the angle. It doesn't do this, it doesn't do that. It angles inferiorly as you go medial, right? Inferiorly as you go medial. But people kind of visualize the scapula as having this sort of triangular shape here, and you forget that that scapular spine actually runs in the opposite direction of the superior border of the scapula, right? So it's like this. Yep, okay. So last point, thank you, is that the medial border of the scapula is not straight typically, unless they have a lot of scapular dysfunction. It doesn't run straight superior to inferior. The inferior border, or the inferior part of it, it angles laterally like this. So it kind of simulates my pen right there, hopefully you can see it. It's a little bit like that. So if you are trying to isolate this area to either treat that medial border along the inferior aspect, or even more importantly, the posterior aspect, the inferior portion of the infraspinatus and the teres minor, remember that this border moves out laterally, because what you don't want to do is to mistake the posterior angle of the rib for the scapula. That's dangerous, right? Because here you can go with impunity all over the place and you can be safe, but over here obviously you got the lung, right? So you got to be really careful about distinguishing that medial border from the posterior border of the rib. Again, it seems like kind of a silly thing, like, well, that seems obvious. But again, in these bigger people, it can be really hard to palpate. And so using these strategies of, for example, Mark, if you can kind of put your hand behind your back, things that can kind of, try to pop, kind of get some popping out of that scapula so you can better palpate right there, can be very, very useful. It's going to keep you safe.
But it's very mobile. Look how far it's moved.
Yeah, look, yeah.
When he moves it, look how far off the marks are now.
Yeah, see?
So
Yeah.
that infralateral border of the scapula is very mobile depending on humeral position.
And why is it so mobile? Because it doesn't attach to anything, right? There's no articular joint there. It's just, again, a bunch of tendons and ligaments in there.
One more quick safety mention, that infraspinatus fossa, where the infraspinatus is, you'll definitely find lots of trigger points. That bone can be paper thin. Like if you take a live scapula and hold it up to a light, you will see the light through it. It can be translucent thin. Not uncommonly, there are congenital foramen, like a non-ossified center. So yes, there should be bone there, but approach it very gently as you get close to the bone, because you can poke straight through it with a stiff enough needle.
And especially with some of your older, thinner, osteoporotic women, especially
Can you
careful.
mark the position of the infraspinatus?
So positioning wise, yeah, people talk about this Jack Benny. I don't even know how many people know Jack Benny, but Jack Benny had this famous poster. He's like kind of like this, right? So let's rotate you in the chair again. Yeah, so it's basically like this. Now, I did see one station yesterday that they were attempting to do this, and the patient was kind of like, it was a very uncomfortable position for the patient, all that kind of stuff, and the patient was literally holding their own arm sort of like this, and holding it up like that. So you want to keep it in close, and the idea is that you are pulling into adduction, and you're getting a little bit of external rotation. That's why you have your hand on the chin like that, right, to expose that greater tubercle, the inferior posterior aspect of where that infraspinatus attaches, and you can actually palpate it, and it's going to be, you know, kind of right in that area right here. So it does expose it pretty nicely for injection.
So are we able to, like, just, let's say for example, my touch is not so good, can I use the scapular spine and then just kind of say, I fall off the mountain and I'm there?
It would be probably the inferior aspect of the scapular spine. Yeah, so if you go directly over it, you're gonna kind of be in this sort of, it's a little hard to tell. I can't tell exactly where I am. I can feel deltoid, but I'm not feeling the notch. So right there I can feel it, and you're gonna be kind of coming in like kind of right in there.
It's gonna be, in that position, you're really exposing a lot of the articular cartilage, so your target structures are gonna be up to, we did this when we were working on the book, we measured it, like the different positions. The attachments can vary as far as being like right juxtaposed with the glenoid rim to like 5 centimeters away with just like internal and external rotation, let alone like multiplanar motion. So you really have to be able to palpate at that point. So
They're hard. Yeah, that's actually.
and here, if you can't feel it, then you know call one of us over.
It's a
We'll
great
help you-
spot.
Help you tell with the
Quick
sense. but-
question. How do we treat shoulders here, like sitting down or laying down? Because you can do that laying down, it's easier.
Yes,
For
so,
some people,
so,
though.
so the question is, do we treat shoulders lying down or sitting down? It is going to be at your discretion, working with your instructor. However, if you're going to treat a patient seated, I have a very specific way of doing this. And I'll admit I get a little bit annoyed when I see patients like sitting, hold on, I'm not gonna chrome this table here. But, you know, when they're sitting like this and they're unsupported, because I've had it, I've had a couple of close calls of patients, you know, almost vasovagaling. I had one patient that did vasovagal, and that was scary as hell. Actually, it was my first or second year in Guadalajara, and we had a 13-year-old girl sitting there. We did her cervical. She did awesomely through the whole case. The last spot, sat her up to get second rib. There's a seated second rib technique that I had learned. And then right when I put the needle in there, she does this. I'm standing behind her, concrete floor, high table. My assistant, thank God, was standing in front of her and caught her, because if she didn't catch her, she would have had a traumatic brain injury. She might have died. I mean, who knows what? It would have been horrible. So what I advocate is, let's say that you're treating the right shoulder. You have a chair with a back, and they slump a little bit in the chair, and then their non-treated side leans against the table a little bit like this. Now it does make them a little bit crooked, but you know, it's not that much. And in this way, if they vasovagal, they're safe, right? Either if they have too much tequila. So I like to make sure, because the thing is, you never know when a patient's going to vasovagal. Now, if a patient has a history, you can plan for it. But if you do this long enough, you treat a couple thousand patients, you're probably going to have somebody vasovagal on you that you don't expect, you know? And if they're sitting unsupported, you know, you think you're going to catch them, you know, good luck with that, because you got their entire body mass, because they're unconscious, right? It's you know, and you're holding a needle, you know, you really think you're going to be able to catch them? Unlikely. So now here, of course, if you're treating, if they're short or the table or the chair has a high back, you're trying to get that posterior aspect, you got to adjust a little bit, right? So maybe for the posterior scapula and interarticularly have them do something like this, or maybe you have them sit forward a little bit, but they're still supported here. Point being that you want your patient properly supported, not to mention sitting like this is pretty comfortable. You know, if I'm going to get jabbed with needles and stuff like that as a patient, this is generally better than just sitting on top of this table and you feel a little bit like you're on display or something like that, you know? So that's what I recommend for a seated position. Yeah, but again, at your discretion, depending on what's easier, you know, and all that. Yeah. All right, so I think we're probably